Hi, my name is Ryan Lauerman, and I'm part of the physical therapy program at Campbell University. Today I'll be going over the anterior hip mobilization. Now, the hip mobilization is a common intervention used to treat joint restriction and limitations at the hip. The many benefits of performing a mobilization technique include improvement in extensibility of restricted capsule ligamentous and soft tissue to stimulate mechanoreceptor activations, decrease pain, decrease muscle spasms, and improve blood flow or nutrient exchange in the joint. The joint that will be mobilized today will be the coxofemoral joint, which entails the femoral head and acetabulum of the pelvis. So here I have a replica of the coxofemoral joint. This is the anterior aspect of the joint, and this is the posterior aspect of the joint. When providing this mobilization, we're going to place our hands on the proximal femur as close to the joint line as possible and provide an anterior force. What this will do, this will increase the joint play and anterior capsule stretch, and the main benefits of the anterior hip mobilization are to improve the patient's hip extension and external rotation. We can utilize anywhere from a grade 1 to 4 mobilization on the hip based on patient presentation. Grade 1 and 2 are primarily used for pain dominance, where grade 3 and 4 are used for stiffness dominance issues. For the rest of this presentation, I will be providing a grade 3 mobilization, which by definition is a large amplitude, rhythmic oscillating mobilization to the point of limitation in range of movement. So I will now perform the anterior mobilization in the neutral position. We're going to start with the patient in prone, and I'm going to put this towel roll underneath the distal femur. So what I'll do next is I'll bend the knee to about 90 degrees, and then I'll place my hands, specifically I'll place one hand, my hypothenar eminence, on the proximal femur closest to the joint line, and then I'll place the other hand over top. And what I'm going to do is I'm going to do the grade 3 mobilization. So I'll push down anteriorly, hold that for 10 or 30 seconds, and I can perform this 3 or 5 times. Afterwards, I would reassess and see if extension or external rotation have improved. So now I'll be performing another anterior mobilization technique, and this one will be a progression from the first. So what we're going to do is we're going to have the patient in prone, and then I'm going to take his leg into flexion, abduction, external rotation. I'm going to put his other leg over top his ankle. Same hand placement. I'm going to place my hypothenar eminence on the proximal femur closest to the joint line, and my other hand over top. And I'm just going to provide a grade 3 mobilization for 10 to 30 seconds, 3 to 5 times. And then afterwards I would reassess extension and external rotation to see if those have improved. After performing the assessment, what I found was restriction in your left hip. So what I'm going to do is I'm going to perform a technique to help decrease pain and help with movement of that hip. Does that sound good?
Sounds good.
Did you have any questions?
No.
All right. Can you lie on your stomach for me? So I'm going to put this towel roll under your knee. I want you to just relax. So I'm going to push down into your hip. I want you to let me know if this causes you any pain.
Okay.
Is that okay?
Yep.
I'm just going to do this a few times. One more. In 2007, Courier et al. Presented a level 4 study that favors at least a short-term decrease in pain in people that have knee osteoarthritis after they have undergone 4 different hip mobilizations. These glides include caudal, anterior-posterior, posterior-anterior neutral position, and posterior-anterior in the favor position. Of the 60 participants, 41 of them had favorable short-term responses to the hip mobilizations. The criteria for these hip mobilizations was based on the clinical prediction rules of knee osteoarthritis and is as follows. Hip or groin pain or paresthesia, ipsilateral anterior thigh pain, passive knee flexion less than 122 degrees, passive hip internal rotation less than 17 degrees, and pain with hip distraction. This study provides an alternative intervention for those suffering from knee osteoarthritis, yet further research is needed based on the level of evidence. Burns et al. Presented a case series in 2011 in which 8 patients with chronic low back pain received exercise and hip mobilizations. The hip mobilizations utilized in this study included posterior anterior in the Faber position, posterior anterior in a neutral position, and anterior posterior glides. 5 of the 8 patients reported feeling moderately better by the 3rd session and had a 24% reduction in Oswestry Disability Index with this treatment. A neurophysiological mechanism may be a reasonable explanation considering the clinical outcomes of this study in treating chronic low back patients. Still, a large sample size is needed to establish the effectiveness of this intervention. Uries et al. Presented a randomized control trial in 2013 in which 40 participants were placed into either a control group with the use of a grade 1 posterior anterior mobilization and an experimental group in which they used a grade 4 posterior anterior mobilization. The participants performed a pre-test, post-test of 5 isometric repetitions on the Cybex norm isokinetic machine, and the peak torque was determined. The study found a significant difference between the experimental and control groups. What was found was a significant increase in gluteus maximus strength in response to the grade 4 posterior anterior mobilization. Clinicians can utilize these findings in everyday practice to improve muscle strength by integrating manual therapy with therapeutic exercise.